This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 74 for April 8th, 2022. We're calling this one the Brief Resolved Unexplained Event, also known as a BRUE. I want to welcome all of you to the program. So we have another resident-led episode of the podcast for you this week as we consider, as I said, the Brief Resolved Unexplained Event, or BRUE, which in a nutshell are events that happen to babies under the age of 12 months. They last less than a minute, but they're frightening to the observer because the baby may appear to have difficulty breathing or turn pale or blue in the face. They may be unresponsive or limp and floppy, but the important thing is it is a short-lived, isolated event, and then the baby looks completely normal afterward. And when they present to the medical clinic to be checked, or the urgent care or the emergency department, BRUE is a relatively new word with widespread use beginning in 2016. Prior to that, from 1986 to 2016, these events were called ALTEs, which stands for Apparent Life-Threatening Event. However, that terminology was felt to be too fear-provoking for both parents and providers, to call it an apparent life-threatening event, because the majority of these events, in fact, the vast majority, are not life-threatening. But because of the terminology, there was a lot of worry and unnecessary medical workups for these kids. Now, prior to 1986, an even worse name was used, near-miss SIDS. SIDS, of course, means sudden infant death syndrome. We now know that BRUEs are not related to SIDS, but they're not always benign either. And in fact, we can divide them into low-risk and high-risk versions of the event, which makes a difference on risk for future events and how management of the problem moves forward. Now, as I mentioned before, our resident-led episodes are conceived, researched, and presented by pediatric residents at Nationwide Children's Hospital. And today is no exception. These episodes, by the way, are designed to cover really foundational knowledge in pediatric medicine and are geared with learners and new practitioners in mind. But there's also they also serve as a useful review for those who have been around the block a few times. And we have two terrific pediatric residents joining us this week, Dr. Meghan Fennell and Dr. Vanessa Thiel, again, both pediatric residents at Nationwide Children's Hospital. Before we get to them, let's cover our usual quick reminders. Don't forget you can find PediaCast wherever podcasts are found. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of that education credit, it is easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. And by the way, we do offer credit to many pediatric professionals, of course doctors, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And then we have that handy contact link over at PediaCastCME.org if you would like to suggest a future topic for the program. Also, I want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Our discussion may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment options, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Meghan and Vanessa settled into the studio, and then we will be back to talk about the brief, resolved, unexplained event, or BRUE. It's coming up right after this.
All right, so today we are talking about the BRUE, a classic hospital pediatrics topic. So right off the bat, Meghan, can you tell us what exactly a BRUE is?
Absolutely. Let's just start by saying that babies do some very strange things sometimes. Sometimes we can explain why that happens, and sometimes we can't. And when a baby has a specific type of episode that we don't have a medical explanation for, we call the event a BRUE, which stands for a brief, resolved, unexplained event. By definition, this occurs in a baby who's less than 12 months old, and the event is brief, less than a minute by our definition. These also can't be explained by any other medical conditions, so getting a great history and physical is very important with this diagnosis. It can be really difficult to figure out what truly is a BRUE and what can be explained by something else.
Gotcha. Well, thanks for introducing that to us. I do have a quick question before we start to get into the details of a BRUE. Just some terminology that I want to ask right off the bat. So is the BRUE the same as an ALTE? And can you tell us what an ALTE is?
That is a great question. They're similar, but there are some key differences to highlight. An ALTE is an older term that was used from 1986 through 2016. An ALTE stands for apparent life-threatening event. This was defined as an event that was observed by a caregiver and characterized as frightening. It also had to include some combination of apnea, color change in muscle tone, choking, or gagging. This was an okay term. It gave us an idea of what happened, but there were a couple issues with it. One is that it's a really broad term, and it also relies on someone subjectively characterizing an event as frightening. And secondly, it probably led to some unnecessary caregiver and provider concern that led to some more extensive and unnecessary workup, more than what we needed.
Yeah, I bet. I mean, any diagnosis that includes the term life-threatening sounds pretty scary to me.
Exactly. And what's even scarier is the term that was used prior to 1986, which was near-miss SIDS, SIDS standing for sudden infant death syndrome.
Yikes. So are BRUE and SIDS related then?
They're not. That's a great question. I'm glad you asked that. So I'm really glad that the term near-miss SIDS was retired. We have some evidence showing that the two are not related. In the 1990s, the American Academy of Pediatrics started the Back to Sleep campaign, which was designed in part to combat SIDS, or sudden infant death syndrome. This campaign recommended that babies be placed on their backs each and every time that they sleep. With this practice change, the rate of SIDS deaths fell by about 40%. However, ALTE rates, which the terms were called ALTE at the time, ALTE rates stayed about the same. If the two were related, we probably would have expected those two numbers to trend together.
Gotcha. That makes sense. Thank you for explaining that to us. So just to reiterate and clarify, the term ALTE is out, and we should definitely be using the new term for it, which is a BRUE or a BRUE.
Exactly. This 2016 clinical practice guideline from the American Academy of Pediatrics recommends the replacement of the term ALTE with the newer and more accurate term of BRUE.
Great. So to further introduce our topic for today, let's start with a case. So do you want to tell us our first case for the day?
Sure. Let's talk about Brianna. Brianna is 6 months old. She was born at term at 39 weeks via uncomplicated spontaneous vaginal delivery, who was brought to the emergency department by her parents today. They're very concerned. They report that earlier today, Brianna had an episode about a minute long when she started coughing, seemed to be gasped for breath, and she looked a little bit blue around her mouth. She then kind of went limp, unresponsive, and mom called 911 while dad started patting her on the back. By the time that mom got off the phone with 911, Brianna was really back to her normal self. EMS came to the house. They didn't have to perform any interventions because the baby looked well at the time. but they still brought the family to the emergency room and they're here to be evaluated.
Gotcha. It definitely sounds like a scary event that happened at home.
This is absolutely a scary event for any family. So let's unpack how we might approach this patient. First of all, do you think this is a BRUE?
All right. Well, our baby is less than 6 months old, and it sounds like the episode was brief. So I think it could be a BRUE, and I'm sure this is on our differential, or many of us would put it on our differential. But to make sure, I think we have to ask a lot more questions. And I think a thorough history and physical exam is super important because, like the term itself says, it needs to be unexplained. So we really have to unpack this differential first.
Exactly. I'm glad you mentioned that. Many times an infant can come into the emergency department or even get admitted with the term BRUE attached as a diagnosis, but we definitely want to avoid confirmation bias and get a good history and physical exam.
Yes, exactly. So the first thing on my differential that I would go through is something like a neurological cause, such as a seizure. I've definitely seen some seizures prevent very similarly. So I would want to ask more questions surrounding this differential. Was there any rhythmic jerking or stiffening or unusual eye movements or eye deviation? I would also ask about family history of seizures and if Brianna has ever had any movements like this before. I would also want to know about her developmental milestones, and that's important in asking a history for any baby. We always want to ask about developmental milestones, and we want to ask about pregnancy history. Were there any complications during her pregnancy, any positive serologies that we should be aware of, or any birth trauma? And on exam, when we're looking for a neurological cause, we may be looking for low or high muscle tone, asymmetries in tone, muscle weakness, or of course, abnormal mental status on exam.
Exactly. And seizures aren't the only thing on our differential when we think about neurologic causes. We also think about neuromuscular disorders that may be undiagnosed, structural brain abnormalities. We think about intracranial masses and strokes. All of these things are very uncommon in babies, but when an infant presents with apnea, it's important to consider a central or neurologic cause of that apnea.
Exactly. I would also want to know how Brianna has been over the past couple days and if she's had any signs of infection, because any serious infection like sepsis or meningitis could definitely lead to a seizure or a BRUE-like event. So again, I think it all comes back to history and exam. I would want to ask if Brianna had a fever at home, if she was acting differently, was she any more inconsolable or any more fussy than normal? Is she fatigued or lethargic? And of course, I would want to pay attention to how she looks now. In the absence of that history, and if she's looking well on exam, then I would think something like this would be a little less likely.
Exactly. And really, it's any kind of infection can cause an event that looks like a BRUE. Anything from upper respiratory infections to urinary tract infections or things like meningitis too. For example, if we learned that a baby had some nasal congestion, fever, some increased work of breathing, that might clue us into some kind of upper or lower respiratory tract infection. And it might tip us off to maybe there was a mucus plug that temporarily obstructed the airway that could help explain some of our breathing symptoms. So it's really important to get a thorough review of systems and to ask about sick symptoms. Although let's also keep in mind that babies who are young infants with immature neurologic systems and immune systems might not have a fever, even though they have some of these other symptoms at presentation. When a baby comes in with symptoms like these, we ask about vaccination status, recent sick contacts or exposures. And of course, we always ask a birth history as well. Any maternal serologies that were positive could clue us into a sepsis risk. So moving down our differential from infectious causes, let's also think about some important GI-related causes.
Oh, yes. So I think one important thing to do or to look for is reflux.
Yeah, that's really common. When it comes to this type of event, we think about reflux and we try to get a really good, thorough feeding history. For example, we ask when in relation to the baby's last feed did the event in question occur. We ask, was there anything coming out of the baby's nose or mouth? And what did it look like? Did it look like formula or milk? We also ask what type of formula a baby takes, how much the baby takes, and how often. If a baby is being overfed, that can lead to increased spitting up, which could in turn lead to a choking event that presents like this. Another thing we think about is any feeding difficulties like choking or gagging, and that could be a sign of either anatomical issues or abnormalities or problems with coordinating suck and swallow. If the event occurred close to a feed and it looked like formula was coming out of the baby's nose or mouth, well, then that makes us think that reflux is a likely cause. Sandifer syndrome is an uncommon presentation of reflux, but it can look like head, neck, or back arching. And so thinking about a presentation like that could help explain some tone changes if a baby presented with something like that.
Gotcha. All good points. One more thing I think to keep on our differential that is super important not to miss is congenital heart disease, or CHD. I think anything from a structural abnormality to an arrhythmia should be kept on our differential because babies with undiagnosed heart disease are at high risk for morbidity and mortality, especially in the first months of life. Now, of course, by law, we have congenital heart screening that's usually done in the newborn nursery in 49 states. And it's offered in California. But even if a baby passes his or her newborn screen in the newborn nursery, that doesn't completely rule out CHD, of course, because these tests are not 100% sensitive. In babies with potential BRUEs, we, of course, have to look at any historical features that would kind of clue us into heart disease. For example, if the baby had multiple episodes of cyanosis or has had retractions at home, if the baby's had feeding difficulties, classically, we look for sweating or fatigue with feeds or any sort of choking or gagging with feeds. We also want to make sure we're paying attention to the baby's growth curve and make sure that the growth is intact and there's not any sign of failure to thrive, because oftentimes that is a sign or that could be a sign of CHD. And of course, history, always important. We want to ask about family history of heart disease in the family, either in infancy or in childhood. And I always ask if there's any history of sudden cardiac death. A lot of the times families don't necessarily know what that is, but I always ask if anyone has passed away very suddenly, particularly at a younger age.
Those are all great questions to ask. Let's go back to our case for a couple of minutes. As a reminder, we have Brianna. She's 6 months old and a term female. She was brought to the emergency department by her parents after an episode in which she had irregular breathing and gasping, looked blue around the mouth, and seemed to go limp or unresponsive for about a minute. We can ask the family some additional questions, and we'll learn that Brianna was born after an uncomplicated pregnancy and delivery went smoothly. We learned that she has met all of her development milestones on time up to this point, and we got a good review of systems. It's generally negative. She has no signs of being sick, as well as no sick contacts, and she didn't have any abnormal movements during this episode. On physical exam, we don't identify any specific concerns.
That sounds great. So now do we think this is a BRUE, and what do we do?
Well, that's our big question. So let's go back to the definition of a BRUE. Brianna is eligible to be defined as a BRUE because she's less than a year old, and this event happened over about a minute or a little bit less. So we'll look at our criteria. 1, we look for cyanosis or pallor, and we learned from her parents that her lips were blue. Secondly, we look for absent, decreased, or irregular breathing. It sounds like she did have irregular breathing and was gasping during her episode. We look for a change in tone, and she fulfills this criteria because she went limp during this episode. And lastly, we look for an altered level of responsiveness, and it sounds like she was not responsive to her parents during this episode. So if we can't find any other medical explanation for what happened, we can classify this event as a BRUE.
All right, so we have a BRUE. Now, what do we do?
Well, now that we've identified it, we can go into risk stratification. We identify high risk versus low risk BRUEs, and low risk means that babies are unlikely to have a serious undiagnosed underlying condition, unlikely to have recurrent events or adverse outcomes. The low risk classification depends on both characteristics of the baby and characteristics of the event. To call someone low risk, they have to be at least 60 days old, have to be born after 32 weeks of gestational age, and even if the baby's term, any baby has to be at least 45 weeks post-conceptional age. In addition, for a baby to be low risk, this has to be a baby's first event of this type. The event had to last less than a minute and without CPR provided by a trained provider. And lastly, we can't have any concerning features on history or physical if we're going to classify this as a low-risk BRUE. Once we decide that these qualifications are met, we can go down a low-risk pathway. We also have a higher risk pathway for babies who don't meet this criteria, and higher risk babies might need some more extensive evaluation and possible hospitalization.
All right. So seems like Brianna meets the low risk BRUE classification, and she's in the emergency room right now. So is there any reason to admit her?
That's a good question. In the past, it wasn't uncommon to admit babies who presented in this way. However, we now have some AAP guidelines and some literature that tells us that babies who present with a lower risk BRUE don't have an increased risk of cardiovascular or other events during admission if they're admitted.
Okay. So what about short-term monitoring for a period of time in the emergency room, for example?
That can be a great idea, especially because we're only going to be seeing this baby for a short period of time in the emergency room. It can be helpful to establish that their physical exam continues to be normal and that their vital signs continue to be normal. The AAP guidelines recommend a short observation period in the emergency room. This period can range anywhere from 1 to 4 hours, and there isn't really any established agreed upon time. But again, it can be useful and reassuring to both providers and parents to see that the vitals and physical exam remain stable throughout this short observation period.
Gotcha. Okay, so I would like to observe Brianna for a little bit, but I'm thinking back to our differential, and I know we mentioned some infectious causes that could have led or explained our event, and I'm wondering if there's any reason we should do maybe an infectious workup for this low-risk BRUE, even like a chest x-ray or maybe some lab work. What do you think?
Well, it all depends on our history and physical exam. In pediatrics, we like to avoid unnecessary radiation where we can, and we like to avoid unnecessary needle sticks and lab work if it's not going to be helpful to us. For example, if a baby is well appearing without any infectious symptoms and their lung exam does not suggest something like a pneumonia, then doing a chest x-ray is some extra radiation that's not really going to change our management. So it's probably not going to be necessary. The literature shows us that in a low-risk BRUE in a well-appearing infant, the likelihood of a serious bacterial infection is pretty low. The guidelines will also tell us that viral testing and urinalysis aren't routinely indicated. And again, we perform testing based on our history and physical exam. So if your history leads you to suspect a diagnosis other than a BRUE, some additional testing might be necessary to investigate that diagnosis a little further.
Okay, so she looks great. So I don't think a CBC or cultures or anything would be indicated for her right now with this reassuring physical exam.
I agree. The one infectious disease test that we can consider in routine low-risk BRUEs is testing for pertussis. And we consider that because pertussis can cause gagging, gasping, color changes, and then a pause in breathing several days before a baby develops other respiratory symptoms. So when considering this, we ask ourselves a couple of questions. We ask about the baby's vaccination status and the vaccination status of any family members who live with them. We ask about known pertussis exposures and the prevalence of pertussis in the community. It's important to remember that babies are protected against pertussis by DTaP vaccination, which is diphtheria, tetanus, and acellular pertussis. Most babies should receive that vaccine for the first time at the age of 2 months.
All right. So we've determined that Brianna is a low-risk BRUE. She doesn't require inpatient admission right now, but we are monitoring her for a brief 1 to 4 hour observation period. We also could check for pertussis, but she's up to date on her vaccinations and she has no other risk factors. So thinking back to our differential, I also thought about a neurologic cause. Is there any indication for a neuro workup?
It's a good question. The available evidence right now shows us that performing neuroimaging in low-risk BRUEs is pretty low yield. Even if we get some more history that does sound like a seizure, neuroimaging is usually not indicated in first-time seizures as long as there's no additional concerning history or physical findings. Again, it is all based on our history and physical exam. If you're interested in learning more about seizures and how we work them up, please check out PediaCast CME episode 48, where Dr. Mike will further discuss seizures.
All right. So again, Brianna is 6 months old. She's full term. We don't have anything concerning on our history or our physical exam. She had this very brief episode of irregular breathing and color change, hypotonia, altered responsiveness. We don't believe admission is necessary. We don't believe further infectious workup is necessary or a neurological workup is necessary right now because it likely wouldn't be high yield considering how good she looks on exam. So you're about to leave the room and then parents do mention that about maybe 30, 40 minutes prior, she did just get done with a bottle and she has had some random intermittent reflux and spit up before. So what does this make you think? Does this change anything?
Well, that brings me back to something on a differential that we talked about earlier, and I'm wondering if this could have been reflux.
Yeah, exactly. So gastroesophageal reflux, or GERD, is a very common thing to keep in our minds that could potentially lead to something like an airway obstruction or a laryngospasm or possible aspiration. Importantly, if this is the case and we think that this caused the event, then I guess it's not a BRUE anymore because it explains the event. But sometimes we can consider it as contributing to a low-risk BRUE, especially if the patient's symptoms aren't necessarily witnessed or maybe well described by our caregivers, or maybe they're outside that time frame where you would expect reflux to be happening or contributing to this event.
So if we suspect that this event was caused by reflux, is there any utility to doing some extra testing or treatment?
Right. So the available evidence right now really shows no utility to routine diagnostic testing to evaluate reflux in these patients. Could consider an upper GI, but it's only a snapshot and it can lead to false positive or false negative results, because it could show results that don't necessarily correlate with the degree of actual inflammation, or you may not see anything and it just may not have happened at that time. So you'd really only use it to look for an anatomic abnormality, which then would totally preclude the diagnosis of a low-risk BRUE anyway. You could use multiple intraluminal impedance probes that are useful to detecting both acidic and non-acidic reflux, and it's been used in trying to correlate reflux symptoms with respiratory symptoms like apnea or cough. But again, it's not indicated for a lower risk BRUE event. One intervention I think that would be great to consider is speech therapy. So especially in cases when you think there is a poor suck-swallow mechanism or poor suck-swallow breathe coordination that could have led to coughing, choking, and laryngospasm, that's definitely a situation where our friendly neighborhood speech therapist can really help out.
Okay. Well, what about treating reflux with medication? Would that be indicated?
Great question. And I think the topic of reflux and treatment with acid suppression could probably be a whole podcast on its own. But to keep it short and sweet, really, the guidelines don't indicate that there's any efficacy for acid suppression therapy in our low-risk BRUE patients, especially if there's not any concern for growth or development.
Okay. Well, we've talked about quite a bit. The BRUE certainly has a very long differential, and there's a lot to think through in a baby who presents this way. But I do want to talk about one more thing that we should always keep on our differential, and that is NAT, or non-accidental trauma.
Yes, definitely. I think it's so important to really never forget non-accidental trauma and to always keep it in the back of our minds, especially if there are certain things on our exam that should get our attention.
Exactly. And that's really difficult because sometimes child abuse comes with a very subtle presentation. But we always start with a history, and we have to make sure that our history makes sense. We think about, are these events plausible? And we ask ourselves, Is this history changing a little bit too much as the caregivers tell the history to different providers throughout their ED stay? We make sure that the history is consistent with the developmental status of the baby. For example, if a caregiver tells us that a 1-month-old baby rolled out of bed and that's their mechanism of injury, that is a red flag for us because developmentally typical 1-month-olds should not be able to roll over.
Gotcha. Also, speaking of changing histories, I do just want to mention that it can be super hard at first for caregivers to accurately recall events because it was very scary, it was super traumatic, and I'm sure time stands still at the moment. So certain things may be within reason to change on our history. For example, like I said, time may stand still, so it may feel like this event happened for maybe over a minute, a couple minutes. But once heads are clear and things have calmed down, it's totally natural for parents to realize, maybe this wasn't as long as we thought it was. Maybe it was less than a minute. Maybe it was more like 30 or 40 seconds, and it was just really scary at the time. Things like that are within reason to change in our history, but definitely stories that are very inconsistent or don't match developmental milestones, like you said, Meghan, those things are super concerning.
And another thing we have to think about is the physical exam, keeping in mind, of course, that a normal physical exam never rules out abuse. There are some specific things that we look for. Any type of bruising in a non-mobile infant is concerning, and as well as bruising in any unusual or atypical places, like on the abdomen. Thinking about our exam going from head to toe, in a baby, we can look at their fontanelle. A baby who has been a victim of head trauma might have a bulging fontanelle, may be extremely fussy or otherwise have an abnormal mental status. We can move down a bit and look at the eyes. And a detailed ophtho exam could show us findings like retinal hemorrhages, but even on the surface, we can look at a baby and assess for subconjunctival hemorrhages. We look for blood in the nose or mouth, and in the mouth, we check 3 frenula. We check the top lip, the bottom lip, and under the tongue. In babies with occult fractures, you might find crepitus on palpation or some unexpected point tenderness. Likewise, a baby may also be fussy out of proportion to what you might expect.
Gotcha. So with a BRUE, or a low-risk one, is there any indication to do a further workup for non-accidental trauma, like imaging, a skeletal survey, or head imaging at all?
That's a great question and an important one to ask, since we just said that child abuse can present with a normal exam. However, unless we see red flags on our history or physical exam, we probably will not need imaging like a head CT or skeletal survey in kids who present with a low-risk BRUE. We have some literature backing this up. We have some older literature based on the old ALTE term that was used prior to 2016. Babies who presented with ALTEs had a low incidence of head trauma, somewhere between 0.5% and 2.5%. We have some more recent literature that is specific to low-risk BRUEs, and that tells us that the incidence in this population drops even further to less than 0.3%. So all of this goes to show us that we really just need a good history, including a good social history. We learn where the baby lives, who takes care of the baby, and the type of environment that they live in. We talk to the caregivers and assess things like, does this caregiver have unrealistic expectations of what the child should be able to do? We also learn, does the baby live with anybody who has problems with substance abuse or addiction, mental illness? We want to know if the baby is exposed to any domestic violence or intimate partner violence at home, or if anyone who cares for them has involvement with child protective services or law enforcement. We work with social workers very closely, but medical providers should also be able to get this history from families. This history is important, one, because it raises red flags for abuse if we find something unusual, and secondly, we might be able to help families out by helping them meet some unmet social needs.
Gotcha. Yeah. And here at Nationwide, we do have our low risk and our high risk BRUE pathway. And for both of these, we always have social work come and evaluate the family. It's actually a requirement prior to discharge.
Well, talking about non-accidental trauma was definitely a good idea before we wrap up our case. So, as a reminder, Brianna is our 6-month-old term female who is a low-risk BRUE based on our history and physical exam. Right now, we don't think she needs admission, and she doesn't really need an extensive workup either. We've had our social worker assess Brianna and her family, and they've determined that she does not have any unmet social needs. So, even though we are not going to be admitting her, I want to ask, what are some things that would make us conduct some further investigations or maybe admit a baby to the hospital?
Great question. And great to ask because so far, again, we've been discussing a specific classification of the BRUE or BRUE. We've been talking about low-risk ones. And again, let's just go through the low-risk classifications one more time. So low-risk BRUEs are those where the baby is greater than 60 days old. The baby is greater than 32 weeks gestational age and greater than a post-conceptional age of 45 weeks. The event also lasted for less than a minute, and no CPR was required by a trained medical provider. This also was our first event or our first BRUE-like situation. And of course, we had no concerns on history and physical. So all of these led us to classify this as a low-risk BRUE event. Now, of course, where there's a low-risk category, there is probably a high-risk category as well, which we'll go through the criteria now. So the criteria for a high-risk category includes the following. So the baby was less than 60 days, the baby was less than 32 weeks gestational age, and is a post-conceptional age less than 45 weeks. It's a high-risk classification if this was a recurrent event, or if the event happened in clusters. It's also a high risk if CPR was performed by a medical provider, or of course if there was anything concerning on our history or our physical exam. So any one of those findings should indicate to you that this is a higher risk BRUE.
Okay. So what should we do if we come across a higher risk BRUE? Say we have a baby who was born at 29 weeks and had an extensive NICU stay. Or maybe we have a baby with a family history of congenital heart disease. Or maybe this is a recurrent event and not the first event of this type. What would you do then?
Right. So the evaluation of a higher risk BRUE is super tricky. And in fact, when the 2016 guidelines for the lower risk BRUE came out, there were actually no corresponding guidelines for high risk BRUEs. There is now a high risk framework that came out in 2019, but they do clarify that they are not clinical practice guidelines. It's more of a, like I said, a framework or some guidance to help us through cases. So for higher risk BRUEs, they recommend, the literature recommends a tiered approach that's first aimed at identifying time-sensitive things like non-accidental trauma or congenital heart disease or feeding difficulties. So they do recommend observation for 4 hours. They do say that you can have our social works come and evaluate. We could also do a feeding evaluation at bedside. And for a higher risk BRUE, it is recommended to do an EKG that can look for any sort of heart disease or arrhythmia. We could also do viral testing and the pertussis testing like we mentioned before. So the differential for the higher risk BRUE remains the same, and so do the considerations in evaluation, but we sort of have some heightened concern and maybe some lower thresholds for performing these evaluations.
And then we also ask ourselves, if someone's high risk, do we need to admit the baby? And the answer to that question is a little unclear. The 2019 guidelines for higher risk kids are not quite as directive as the low risk guidelines are. To date, we don't have very much evidence to guide which higher risk infants are more likely to benefit from hospitalization. So deciding on admission should really be shared decision-making between the provider and the caregiver, taking a couple things into account, including caregiver comfort, provider comfort, and ease of access for close follow-up with the primary care provider. At Nationwide Children's, our practice is to admit higher risk BRUEs for at least 16 hours, including one overnight stay. When a baby is admitted, we monitor their oxygen saturations with continuous pulse oximetry, and they receive multiple assessments by hospital staff. when a baby's admitted, we have their family meet with a social worker who can identify any unmet social needs or community resources that the family could benefit from. Social worker can also identify any safety concerns at home. And finally, if we performed any testing or lab work, we make sure those results are normal before the baby goes home. And we also have to make sure that the baby is still well appearing at the time of discharge.
Gotcha. So at this point, would we perform any testing we mentioned earlier, or is that still not indicated?
Well, there's no standard set of labs we get for anyone who is admitted as a high-risk BRUE. We are still guided by our history and physical exam. For example, if we are concerned because there's a family history of congenital heart disease, we would consider this a high-risk BRUE and might want to get an EKG to make sure we're not missing anything. EKGs are a very quick and easy test to do, and even in low-risk BRUEs, the guidelines say that that's something to consider. There is a high negative predictive value of a normal EKG. However, it's also important to keep in mind that the positive predictive value is still kind of low. So that goes to say that an abnormal finding on an EKG is still not very indicative of true heart disease.
Gotcha. All great points. And also one more topic that we didn't touch on yet to always consider are inborn errors of metabolism. So inborn errors that could cause a BRUE-like event are things like a urea cycle disorder, fatty acid oxidation disorder, an organic acidemia, or lactic acidemia. Of course, we would always confirm what our newborn screening results are, but again, that doesn't necessarily detect everything and doesn't exclude the diagnosis completely. It would also be unlikely that issues from an inborn error of metabolism would self-resolve, and typically there are triggers in our history like fasting or an illness that we would get in the history. So we definitely want to ask about those things and take that into consideration. If we do have concerns, things like looking at electrolytes, looking at lactate levels, looking at glucose and our calcium and our ammonia levels, and of course getting a blood gas would all be things to consider if we had this diagnosis in mind. And of course, if we had this diagnosis in mind, we would always call our geneticists. And our physical exam may be concerning for lethargy or a sepsis-like picture. Just always something to keep in mind and to keep on our differential. And to sort of round out our differential for the BRUE or BRUE, let's talk about BRUE mimics. That is normal, healthy baby things that appear scary to a caregiver or even to a provider that kind of seem like a BRUE but are normal baby things.
Well, there are a lot of things that normal, healthy babies can do that might look unusual or scary to a caregiver. First of all, when babies are first born, they might look a little bit blue around the mouth, around their hands or feet. This is called acrocyanosis, and it is a normal physical exam finding. In babies who are born prematurely, we think about apnea of prematurity. That is defined as a pause in breathing for more than 15 seconds or a pause in breathing for any amount of time if it's associated with the desaturation or bradycardia. This is probably something that would have been caught before a mom and a baby leave the hospital. Unfortunately, this should go away with time as a baby's neurologic system matures a little bit. Even term infants can have periodic breathing. And when this happens, a baby can pause in breathing for up to 15 seconds. That might be followed by some faster or more shallow breaths before returning to a completely normal breathing pattern. And again, that's a thing that normal, healthy babies can do. Separate from that, we think about breath-holding spells, which typically start when kids get a little older, typically 6 months or older. And a breath-holding spell is typically triggered by an event that makes the baby angry or scared or otherwise upset. And it looks like a child holding their breath until the lips or face turn blue. They might pass out. Muscles might become stiff or even jerk a couple of times. However, in a typical breath-holding spell, a normal breathing pattern should come back within 1 minute, and the child should be back to a normal mental status and level of awareness within 2 minutes.
Gotcha. Thank you for those great points. I do want to ask one more thing and clarify one more thing that we've mentioned a couple of times throughout this discussion. We've talked a lot about concerning physical exam findings, and I just want to ask what exactly we mean by a concerning physical exam finding.
That is a great question, and it's a purposefully pretty broad term because it covers so many things and it leaves a lot up to clinician judgment. We can see a lot of abnormalities looking at a physical exam. Looking at the head and neck, we might see something like a small jaw, a big tongue, big tonsils, or different craniofacial abnormalities. These are pretty easily seen, but there are some abnormalities that aren't so easily seen, things like choanal atresia or congenital abnormalities of the trachea. And we think about problems like this when we have a baby come in with repeated events or difficulty breathing, fast breathing, snoring, noisy breathing. We also have to consider that a baby might have an airway obstruction because they've aspirated a foreign body. So let's not forget to ask families about that.
Great. Thank you for clarifying those points. So back to our baby, who we found out was preterm. So she is put into the high-risk classification of the BRUE event. So we admitted this baby because she was high risk. We did an EKG. That was normal. We had social work evaluate the family, and they did not have any concerns. And we also had speech combined just to evaluate her feeding skills, and they also did not have any concerns. She's had normal vitals consistently, and she's had a normal physical exam, and she doesn't have anything else concerning on history. She's done great. So we think that she is ready to go home. But of course, this was a super scary event, and parents are very anxious and very worried about going home and are asking, what if this happens again? What do we do? What can we do to help parents as they get ready to leave the hospital?
That's a great thing to talk about because it makes sense for parents to be scared after such an unusual and frightening event. Throughout admission, parents will probably need multiple episodes of counseling and reassurance. Can help build rapport with them as their medical team and help provide some reassurance just through observation after this scary event. But it's also important for us to empower parents before they go home. At Nationwide Children's Hospital, we have our standard practice of making sure that parents are taught CPR before they leave in case they ever need those skills.
Gotcha. So teaching CPR before discharge, don't you think that's a little maybe contradictory? We just got done telling the parents that nothing's wrong and baby looks great, yet we're kind of throwing some CPR teaching at them, which may sound a little scary. What do you think about this?
That's a good point. And it's important to discuss this with parents in a way that's reassuring to them. How we frame this can go a long way in making parents feel more comfortable. It's important to let them know that this is a tool for them that can be handy in many situations and isn't necessarily related to the diagnosis of a BRUE.
Gotcha. So have you found that it makes parents more anxious maybe on going home?
Literature tells us that CPR training has not been shown to make parents more anxious. However, it can make them feel more empowered before they leave the hospital. And in addition to that, increased CPR training really helps community health as a whole. Everybody should know CPR basics, and it can help save a baby's life.
All right. Awesome. Thank you for those points. So to wrap up, our little 6-month-old was discharged. And she did great on admission. And we provided parents CPR training before they left. Also, just want to point out that it's super important to make sure that we have also established close primary care follow-up.
All right, we are back, and it's really a fantastic presentation by our two residents. Before we get to them, I do want to introduce them and chat with them just a minute. Before we do that, though, we do have a number of links for you with resources and references in the show notes. So if you head over to PediaCastCME.org, You'll find those. There's an article from the journal Pediatrics called Brief Resolved Unexplained Events and Evaluation of Lower Risk Infants. There's another one called A Framework for Evaluation of the Higher Risk Infant After a Brief Resolved Unexplained Event. And then Pediatrics in Review, there's an article on SIDS, BRUE's, and safe sleep guidelines that I would recommend that folks look at, especially if you have a subscription to Pediatrics in Review. And then, as was mentioned during the podcast, we had a PediaCast CME episode 48 on seizures and epilepsy. That would also be a terrific one to listen to. So before we wrap things up on the episode, I did want to chat with our residents here real quick. Let's begin with you, Meghan. So what year in your residency are you right now?
I am a second-year resident.
Great. And where are you from? Where'd you grow up? Where did you go to medical school? All that.
I'm from a small town in Northeast Ohio in the Akron-Canton area, and I went to medical school at Ohio State, and I've been in Columbus ever since.
Great. So you are what we call, so far anyway, a lifer at Ohio State because you went to, I'm sorry, where did you go to undergrad?
Miami University, Oxford,
Miami.
Ohio.
Okay,
so not quite a lifer yet.
Okay. You're an Ohio lifer. How's
There we
that?
go. We'll call it that.
And what are your plans after residency?
After residency, I'm hoping to do a pediatric hospital medicine fellowship and become a hospitalist.
Great. All right. Do you see yourself going out of state, or you think you'll try to stay in state?
We'll see. Wherever they take me, I guess.
All right. So Buckeye at heart, or you want to go explore someplace else, you think?
Oh, I'm definitely a Buckeye at heart.
Okay. Yeah. Our family moved to Florida for a few years, and we learned that living in Florida and vacationing in Florida are two different things. And we eventually made our way back up to Ohio. So I don't know, once a Buckeye, maybe always a Buckeye. Vanessa, how about you? What year are you in your residency training?
Yeah, so I am a first-year categorical PEDS resident.
Okay, great. And so categorical PEDS, tell us what that means.
So that's just general PEDS. We also have PEDS neuro, and yeah, just general PEDS.
Okay, great. And so within the pediatric residency, you have, so just to be clear, folks, you go after you graduate from high school, you go to undergrad for 4 years, and you go to medical school for 4 years, and then you have residency after that. And so categorical PEDS is just your plain PEDS, right?
General PEDS.
Yeah.
Yep.
So there is a combined internal medicine pediatric residency just to differentiate, as you mentioned, combined neurology and pediatric fellowship. But you are a PEDS resident, and where are you from originally?
So I am from right outside of Philadelphia, Pennsylvania.
Okay, great. And where did you go to undergrad and medical school?
So I went to undergrad in Westchester, Pennsylvania, Westchester University of Pennsylvania. I went to medical school at Geisinger Commonwealth School of Medicine, which is also in Pennsylvania, and left Pennsylvania for the first time to come here.
Great. So people from Ohio, we call them Buckeyes. What do you call people from Pennsylvania? Is there any special name?
I don't know if there's any special name.
You're just from Pennsylvania.
Yes.
Did you find it funny that we call ourselves Buckeyes?
I am just finding this out now, and I do find it funny.
All right. Like you just found out right now, right this second.
Well, I mean, I knew there were Buckeyes, but I didn't know that you just called yourself Buckeyes.
Oh, yeah. Yeah. Well, those folks who are Buckeyes know what we're talking about.
I'm new here.
Yeah, no. You'll get the hang of it real quick. All right. So thank you so much to both of you. I think you did a fantastic job presenting on BRUEs, as you guys like to say. Us older folks, I think, because we were used to call them ALTEs for so long, and then BRUE just just keep that E at the end, I guess. I don't know. But either way is fine. I say tomato, you say tomato. I actually say tomato too, but I'm sure someone says tomato. All right. So once again, thank you both for being here today. Thank you.
Thank you so much for having us.
Thank you.
All right. I do want to remind you that PediaCast CME can be found wherever podcasts are located. That includes the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, our continuing medical education information, how you can can receive credit for listening to this program. Also, our terms of use agreement and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. So you have listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. It's an easy thing to do. Just head over to the show notes for this episode. This is episode 74, over at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we offer credit to many pediatric professionals, including doctors, of course, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you'll want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also, don't forget about our sibling podcast, Plain PediaCast without the CME. It's an evidence-based podcast for moms and dads. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.